So we are
We
starting the
request
session
everyone to mute their video. Yeah.
Shall we start, sir?
Yes, yes.
Okay, sir. So good afternoon and welcome to everyone. I'm Sreshi from Clanet, and Clanet is one of the largest live digital CME platforms in India where doctors can generate their medical content. Clanet is very proud to be a part as a digital partner for this event organized by National Neonatology Forum Gujarat. And the topic of today's session is PG case presentation, extreme low birth weight child with BPD. Now I would like to hand over this session to Dr. Prashant, sir. He is the Honorable Secretary of NNF Gujarat. Over to you, sir. Kindly proceed with your talk.
On behalf of NNF Gujarat, I, Dr. Prashant Karya, welcome one and all to today's Neonatal Pathshala. I request our President, Dr. Dipin Patel, to introduce the experts for today. Thank you.
Thank you, Dr. Prashant Bhai. Today, on behalf of NNF Gujarat, we have a case presentation from a student who is doing fellowship in neonatology at Urban Newborn Care Hospital. So in this discussion, we have two experts, Dr. Vijay Shah and Dr. Sandeep sir. This presentation will help in mentorship of Dr. Vishal Gohil. So I would like to introduce each presenter and experts in this talk. So first I would like to introduce our presenter, Dr. Komal Mendabara. She is a DCH student. She is currently doing her NNF fellowship at Urban Newborn Care Hospital under guidance of Dr. Vishal Gohil and Dr. Ashish Mehta sir. We have expert. I hope my voice is clear.
Yes, clear.
Yeah, so we have expert Dr. Professor Vijay Shah sir. He is a director and head of the pediatrics Nirmal Multi Speciality Hospital, Surat. He was the former professor and head of the pediatric department, Government Medical College, Surat. He is a postgraduate teacher and examiner and guide for MD, DCH and DNB pediatric students. Welcome, Dr. Vijay Shah sir. We have another expert, young budding DM neonatologist from Gujarat, Bhuj. He is Dr. Sandeep Tilwani. He has done his DM neonatology from Government Medical College, Chengalpattu, Tamil Nadu. He is currently working as assistant professor at Division of Neonatology at Department of Pediatrics, GAIMS. He is interested in infection control in NICU, neonatal nutrition, neonatal neurology, quality improvement, and neonatal nursing care. We have with us Dr. Vishal Gohil as a mentor for Dr. Komal. He is a consultant neonatologist at Urban Newborn Care Center, Ahmedabad. He has done his fellowship in neonatology from Royal College of Pediatrics, UK. He is also a fellow in neonatology from NNF, India. So I welcome you all experts, mentor and presenter Dr. Komal. I hand over to Dr. Prashant Bhai for further process.
So thank you so much, Dipin Bhai. Without taking much of a time, as we are already 7 minutes since today's session, I request today's presenter, Dr. Komal Mendapara, to start the presentation. Komal, please start your presentation. We welcome Dr. Vijay sir and Dr. Sandeep. Both can ask questions on any slides they want to ask. Thank you. Yes, Komal.
Good afternoon, sir.
Yeah,
Hello?
please start presentation. Yeah.
Can we share the screen?
Yes, please, sir.
Komal, please share the screen. Vishal bhai, you can help her.
How can I share?
There is a button at the bottom, share screen. Yeah, that is fine. Make it full screen. Done. Yeah, Komal, proceed.
Good afternoon, everyone. Sorry for the delay. First of all, I would like to say thank you for giving me this opportunity. Myself, Dr. Komal Mendapra. I am doing NIC Fellowship at Urban Newborn Care Center, Ahmedabad. Today, I am presenting a case. Presenting a case of 112 days old male, a newborn of XYZ.
Komal, you may start your video so that everyone can have, if it is possible. Otherwise, it's okay.
Video. They are visible?
No, your video probably.
We are able to see your slides.
Proceed. No issue with video.
No issue, Komal.
Present
Go
the
ahead.
case.
Today I'm presenting a case of 112 days old male, newborn of XYZ. Maturity was 30 weeks and 4 days. Mode of delivery was elective cesarean delivery on 6 February 2023. Birth weight was 600 gram. Informant was mother. Baby was transferred to our NICU in view of extremely low birth weight and preterm care. Antenatal history. Mother is 31 years old, primary. Blood group was O positive. LMP was 7th July 2022. EDD was 13th April 2023. First trimester history. Mother was booked case at private hospital and taken regular antenatal visits at monthly intervals. She tested negative for HIV, HBs, AG, and VDRL. No history of fever, rash, lymphadenopathy, drugs, and radiation exposure. Second trimester history, USG scan was done at 20 weeks of gestation, which showed intrauterine growth retardation since 19th weeks. No any history of pregnancy-induced hypertension, gestational diabetes mellitus, anemia, and thyroid disorders.
Okay, this. Can you go to the previous one?
Yes.
Yeah. Can you go to the previous slide, please? No, previous one. So
Yeah,
say the scan was done at 20 weeks of gestation and showed IUGR since 19th week.
Yes.
Means it has started from the 19th weeks of, like, say previously also a scan was done and it showed like there is an IUGR.
Yes, it was started since 19th weeks. Previous scan was normal.
Previous scans were done and they were.
Yes, they were normal.
Right. Okay. Okay, please continue.
Third trimester history, antenatal visits were taken every 15 days nearby private hospital. Third trimester USG scan and Doppler was done at 30 weeks of gestation, which was abnormal, suggestive of absent flow in ductus venosus and single umbilical artery. Cerebroplacental ratio was less than 1 and IUGR and reduced umbilical flow since 23 weeks. Antenatal steroid given completely and Medsulf could not be given. No history of fever, burning maturation, convulsion, foul smelling discharge, leaking or bleeding per vagina.
So can you please, yeah.
Please ask.
Am I audible?
Yes. Yeah. So I just wanted to ask. You just read that the USG scan and Doppler at 30 weeks of gestation was abnormal. So I mean, what is the significance of the abnormality which you just read? I mean, Yeah, there is an absent flow in the ductus venosus.
Yes.
Okay, okay, so what does that signify? And what is this CPR?
CPR was less than 1. It is a cerebral placental ratio.
Okay, so what does it signify?
It is measured by it is a ratio of middle cerebral artery and umbilical artery flow.
Okay, so when is it significant?
Sorry.
So what is
When
the
is it significant?
I can't
Yeah,
hear.
what is the significance and at what gestation is it significant?
CPR should be more than 1. It should be 1 to 1.1. If it is less than 1, it indicates that delivery should be done.
Yeah. So, I mean, then what is the significance of this ductus venosus, absent flow in the ductus venosus?
Absent flow in ductus venosus, it suggests there is a hamper blood flow to the fetus. So it affects growth of the fetus because oxygenation and blood flow is hampered.
Okay. So I think, I don't know exactly what the report was, but usually what we
Sir,
in this case the IUGR actually started at 19 weeks, right?
Yes.
Nowadays what we call it is FGR, that is fetal growth restriction, right?
Hmm.
So the fetal growth restriction has started at 19 weeks. So what is the significance? I mean, how do we divide it? What is early FGR and what is late FGR?
I cannot hear.
Sorry, am I audible now? Hello, am I
Yeah,
audible
you are
now?
audible, Dr. Sandeep. Dr. Komal, are you able to hear him?
Yes, yes.
Yeah. What is early onset FGR and what is late onset FGR?
Early onset IUGR, which is due to external condition which affect in the pregnancy, or it may be due to any genetic causes, or late onset IUGR which may be due to placental insufficiency or low BMI in the mother.
Okay, so what is the cutoff? I mean, when do you say it is early FGR and when do you say it is late FGR? What gestation?
24 weeks.
No, 32 weeks, right? So if any FGR it starts less than 32 weeks, it is considered to be early onset FGR, and if it occurs beyond 32 weeks, then we tell it as late onset FGR. And why do we make this difference? I mean, why so? I mean, what happens before 32 weeks and why after 32 weeks we are classifying it separately?
Sorry, sir, but I am not able to hear you.
Okay. Sorry.
Minimize करने के लिए चाहो बोलिए.
Am I audible now?
Minimize करो. Escape करें.
Am I audible now?
Yeah.
Yeah. So why do we make that difference between early onset and late onset FGR? I mean, why is it significant to know that difference?
Early onset fetal growth restriction affects baby, because early onset fetal growth restriction affects whole baby, like it reduce the head circumference, it reduce birth weight and length also. Late onset FGR mostly reduce birth weight.
Okay. What else?
Then
Okay, so is there any difference in the management? I mean, if it is a early onset FGR versus if it is a late onset FGR, how would the management differ and what would you see actually? I mean, when you are called to monitor, or I mean, when you are called to attend the delivery, what are the things would you be worried about if it is an early onset FGR? And I mean, how does it differ if it is a late onset FGR?
The,
So as I said, as you rightly pointed out, the early onset FGR is something which it would be more severe. We expect that the IUGR would be more severe, and the outcomes are definitely poorer if it is an early onset FGR. The late onset FGR, they're usually milder ones. Okay, and it is most of the times we can wait up to 37 to 37 weeks for the baby to get delivered. Whereas in the early onset FGR, there are more chances of a fetal compromise, and it may lead to IUD. So as you have pointed out in this case, that every 15 days or even more frequently rather, the baby or the fetus has to be monitored. And what would you look for when you call these mothers for monitoring, for follow-up? One thing is, so one thing is we look for the flow in the umbilical arteries. Okay, absent or reverse flow in the umbilical artery, and second is we look for the ductus venosus. CPR, that is the cerebroplacental ratio, is more important for the late onset FGR cases. Okay, so if the decision has to be taken for delivering a late onset FGR, definitely a CPR of less than 1 would be significant. In early onset FGR, most of the times the CPR, if there is alteration in the umbilical artery flow, the CPR as such goes less than 1. And what they say is you should take a decision to deliver based on the flow changes in the ductus venosus. And that too, in the ductus venosus, what we usually see is there is reversal of the A wave. Okay. So in the ductus venosus flow, if there is a reversal of the flow in the A wave, then only we take it as the child or the fetus is now severely compromised and the delivery is imminent, or rather the delivery should be commenced immediately, right? Yeah.
See,
can proceed.
See, there are other aspects by which you can find out the fetal well-being. So which are they? Like, say, this is what we do, like Doppler study, and then we have find out this here, placental umbilical flow. But then there are certain other tools by which during pregnancy we can find out the fetal well-being also, like say, which are they? Like say count to 10 and then stress test and non-stress monitoring. So these are also few of the tools, and like say biophysical profile, which can also tell us about the fetal well-being.
Hello, I think Komal has an issue with, so I just changed the my screen with the Komal actually. So now I'm the Komal is speaking in my account. So can we go ahead, because we missed the part actually.
Yeah, earlier.
Sorry for that one. Can we go further?
Vital parameters
After
for admission. Temperature about 36.5 degrees Celsius. Heart rate was 148 per minute. Respiratory rate 44.
Yet it was less than 1.5 second.
Am I audible?
We are not able to hear.
After admission, vital parameter was temperature was 36.5 degrees Celsius. Uh, am I audible?
Yes.
Can we wait for 2 minutes because it's network issue or I'm not able to hear.
Okay.
Am I audible?
Yeah.
Vital parameters after admission was temperature was 36.5 degrees Celsius, heart rate 148 per minute, respiratory rate was 44 per minute, CRT was less than 1.5 second, SpO2 95% pre-ductal and 96% post-ductal. Pulses were well palpable in all four limbs. RBS after admission was 40 milligram per deciliter and BP was 58 by 27. Mean was 38. Hospital course in first 24 hours. BB was kept on room air. UVC and UAC were inserted. Blood investigation, sepsis screen, blood culture, ABGA were sent, and IV fluid with calcium started. BB was kept NBM. First blood press at 4 hours of life, which was pH was 7.31, PCO2 37, PO2 was 74, MICA was 18.1, and base excess was minus 7.4, and lactate level was 2.25, which suggests mild acidosis with hypoxemia. First blood report, hemoglobin was 18.2 gram per deciliter. Total leukocyte count was 13,185. Platelet was 1.68 lakh, and CRP was negative 1.08 milligram per deciliter. IV antibiotic were started after admission. First, a chest X-ray, 4 hours of light, which shows mild haziness of lungs, and UVC was adjusted after by X-ray and echo. USG cranial.
Umbilical artery catheter was also done.
Sorry.
UVC is seen in this X-ray.
Yes.
And what about the artery? Okay.
UAC is UAC is not visible.
Okay, you can proceed.
Okay.
Am I audible?
Yeah.
USG cranium was done, which was normal. Structural and functional 2D was done, which was showing no PD and no any abnormalities. Baby had mild abdominal distension, so kept NBM. Otherwise, we was doing well. In first 24 hours, TP and total parental nutrition was started. 46 kilocalorie per kg per day was given in first day.
Okay. Yeah. So if you start TPN, how much with what like dose of protein, calories, and lipids do you start?
I'm not able to hear, sir.
Still not audible?
No, sir. Voice is not clear, so I'm not getting what are you asking me.
Komal, we all are able to hear Dr. Sandeep.
Yeah, I am also able to hear.
Okay. Thank you. I was thinking there's some network issue on my side then.
I think Sandeep, you can just come closer or use earphones if you are having, so that your voice becomes louder.
Yes, sir. Now is it audible?
Perfect. Komal? Komal? Komal, can you listen to us? Can you hear us? Vishal bhai? Komal, you are muted.
Oh. Am I audible?
Yeah. Can you hear me, Sandeep, Vijay sir?
Yes.
Fine.
Okay. Yeah. So am I audible now?
Yes.
Yeah. So my question was, like, you started TPN in the first 24 hours. So with what dose do we start? I mean, for proteins, calories, and like lipids, what dose do we usually start? How much
First
proteins
day.
on day one? How much?
Sorry.
How much proteins do you start on day one?
1.5 gram per kg per day for first day.
Okay.
By end of the third day, 3.5 to 4 gram per kg per day should be given to low birth weight, like less than 1.2 kg. And fat should be started 1 gram per kg per day and increase up to 3 gram per kg per day by end of the third to fourth day.
Okay. And what about the calories?
Calories, total calories, we should give 40 to 50 kilocalorie per kg per day in day one. Then increase by 40 by end of the third day. Calorie should be given 50 to 70 kilocalorie per kg per day.
Okay. And then what is the maximum you target?
Sorry.
What is the maximum calorie intake we target?
If a baby is on only total parental nutrition, then maximum calorie would be 100 to 110 kilocalorie per kg per day.
Okay. Yeah, can proceed. Okay. So, one more question. Yeah, you kept the baby NBM on day one, right?
Yes.
I mean, what is the indication, or I mean, can we start trophic feeds at least, minimal enteral nutrition in this baby?
Yes, we can start trophic feeds, but in this case, baby had abdominal distension, so baby antenatal history suggests your baby had an absent flow and IGR baby, so
Okay.
we can start after 24 hours because there is mesenteric ischemia because of IUGR and hampered blood flow antenatally. So
Okay. What is ADAPT trial? Have you heard about it? ADAPT, ADEPT.
sorry.
ADAPT trial. ADEPT. ADAPT trial. Am I audible?
Yes.
Yeah. Have you heard anything about the ADAPT trial? ADEPT trial.
Sir, don't know adapt.
Okay, yeah. So it was the ADAPT stands for Abnormal Doppler Enteral Prescription Trial, right? And what they tested is whether in the babies with Doppler abnormalities who are born, whether the feeds they should be started immediately or they should be started delayed. Okay, so early introduction versus a delayed introduction of feeds. And what they found is that if you start with minimal enteral nutrition early, uh, the day of reaching full feeds would be earlier, the duration of hospital stay would be less, and overall it does not increase the chances of baby developing NEC. Okay, so as per that trial, and recently after that also many Cochrane reviews have come which say that you can start feeds. Maybe if you don't start on day one, at least within first 48 hours they should be started. Am I audible?
Hello. I just gave my mobile to the Dr. Komal. Now she can clearly talk with you and clearly heard the sound. Sorry for this inconvenience.
Am I audible?
Yeah.
Yes. Yes.
From 24 to 72 hours of admission, on third day of life, topic feeds by EBM was started but not tolerated. So it was stopped. Septic screen negative, blood culture was sterile, hence antibiotic were stopped. By third day, full TPN was introduced. 64.6 kilocalorie kg per day was given by the third day. From day of 5th to 21st day of admissions, minimal RTF EBM was started, like 1 ml 6 hourly. Then it gradually increased and it was tolerated well. On 15th day of life, baby developed again abdominal distension. So X-ray abdomen standing view was done, which shows the gaseous intestine, but no perforation.
Okay. So the child was on exclusive mother's milk?
Yes, uh, only EBM.
Okay. No donor milk, no formula feeds, right?
Yes.
Okay.
For this kept NBM for 3 days. Again, feed started as abdomen was soft and distension was relieved. This X-ray abdomen.
Okay. So what I mean, what is the interpretation? I mean, why was there a distension? What do you like call it then? If there was distension with feed intolerance?
Sorry, sir.
So what is the
The
cause
baby
of
had.
distension?
Yeah.
In this baby, extremely low birth baby, there may be decreased peristalsis or IUGR baby, though so or then this is early signs of NEC.
Yes.
Okay. Were there any systemic signs associated? What systemic signs do you look for?
Uh, temperature instability, feeding
Okay.
apnea, then poor feeding and
Poor feeding, anyways,
tachycardia.
the child is on minimal feeds, right? So either bradycardia, temperature instability, or
No,
some.
sir. No, sir.
Okay. So then, can you call it anything?
No, sir. it just feed intolerance because of
Yeah. Okay. So, I mean, the point is
Yeah.
mostly NEC would be a systemic disease, right? NEC is not a localized disease that is only affecting the intestine. Uh, most of the times, NEC would be a systemic disease. So, you would be seeing some systemic symptoms associated, either in the form of apnea or temperature instability or maybe some metabolic acidosis, thrombocytopenia. Some other symptoms would be associated. Just as simple feed intolerance may not be NEC. Okay. Yeah.
okay. From 22nd to 30th day of admissions, on 22nd day of life, baby developed tachypnea, oxygen requirements appeared. So baby was put on HFNC, flow was 6 and FiO2 requirement was 50% on HFNC. Blood culture was sent and antibiotics was started in view of suspected. Sorry. Antibiotic was started in view of suspected sepsis. Chest X-ray was done. Which shows
So go back to the X-ray. Yeah. So the umbilical catheter is still in situ. Hello.
yes.
Yeah. Just go back to the previous X-ray. No, sorry, the next one. Sorry. Next. Yeah. So the umbilical catheter is still in situ on day 22 of life.
Yes, sir.
Okay. And how much time do we remove it usually? I mean, what is the unit policy?
Generally, we remove within 7 to 10 days.
Okay.
But
I think somebody's mic is on.
some
Shreyanshi, can you mute Dr. S. Jagdeshwari?
Yes, sir. Yes, I'm doing.
Yeah, thank you. Yeah, proceed further. Komal, you are again muted.
am I audible?
Yes.
From 22nd to 30 day of admission, blood report was hemoglobin was 9.8, total count was 17,670, platelet was 6.44 lakhs, CRP was 6.03, borderline positive, and blood gas shows pH was 7.32, PO2 139, PCO2 was 46, BICAP was 17.8, and base excess was -3. Baby was maintaining saturation on minimum settings by the end of 30 day of admission. Flow was 3 and FiO2 requirement was 21 to 25%. In view of GERD, continuous feeds was started and KMC was started.
Yeah. So continuous feeds means, I mean, it was you were giving the feeds like all throughout the day, right?
Sorry.
Continuous feeds means it was given through a syringe pump.
Continuous feeding was started. Yes.
Okay. So I mean, which one is better, continuous feed or intermittent feed?
Intermittent feeding is better because in continuous feeding there is a problem with calories.
Okay.
But
what else?
And with the continuous feed, they
So what they say is, or what the studies have found, that intermittent feeding is something which is more, I mean, physiological. Okay, it causes the release of the GI hormones intermittently, which is sort of more physiological. On continuous feeds, the GI hormones, I mean, the secretion is found to be lesser. And also, to some extent, the continuous feeds, what happens is, when you give continuous feeding, the fat may sometimes precipitate in the tubing, and so
Yes.
the nutrition value of the continuous feed which you are giving comes down. So in general, it is said that intermittent feeding is something which is better. If the baby had GERD, I think, I mean, some of the strategies, non-pharmacological measures would be, maybe you decrease the volume of feeds and increase the frequency of feeds, right? So instead of giving a 2 hourly feed, I can shift to 1 hourly feed. Again, the nursing care, I mean, the care of the baby by the nurses would become difficult. Sometimes the nurses may not cooperate. They would come and fight with you that 1 hour feed is not possible for us. But I mean, that is one of the strategies. And also, what you could do is, I mean, allow the baby to be in KMC, if especially he is on high flow nasal cannula, right? So these are the
Yes.
babies who can be managed very well with the KMC. So if the baby is in KMC, as such, the GER chances would be less. And with the baby in KMC, maybe you can decrease the volume of feed at each time and increase the frequency so as to maintain the volume.
Yes. Yes.
Yeah.
Uh, from 31st to 45 day of admission, repeat sepsis screen was sent. We showed improvement. Blood culture was sterile, hence antibiotic were stopped. Gradually, anti feeding was increased as tolerating well by baby.
Okay. So there was some sepsis, right? I mean, we suspect that the child had some sepsis. So can you call it CLABSI?
Uh, it maybe because
Okay. So when do you label it as CLABSI? I mean, what is the basic requirement? The child had a central line in place, but I mean, when do you say that it is CLABSI? When do you stamp that it is CLABSI?
mm,
So since your blood culture was sterile, it is difficult to say. I mean, maybe the deterioration was because of the central line induced sepsis, but since the blood culture was sterile, I mean, as per the CDC definition which exists at this point of time, we cannot say, I mean, we cannot stamp it as class C because the blood culture is sterile. Yeah. Okay, proceed, please.
from 46 to 60 days of admission, baby was maintaining saturation well on oxygen by high flow cannula. Baby was gaining weight slowly. On 61 to 85 days of admission, baby had distress and increased oxygen requirements. High flow was increased, flow 8 and FI2 requirement was up to 40%. ABGA shows pH was 7.27. PO2 was 32, PCO2 was 64, and BICAP was 28.7. In view of severe respiratory acidosis and severe distress, and baby had two major apnea, baby was intubated and kept on ventilator with PTV mode. FiO2 was 50%, PIP was 24, P5 TI value was 0.4, mean airway pressure was 15, respiratory rate was 40, and tidal volume set PTV mode with VG mode tidal volume set was 4 to 6 ml per kg. After 2 hours of intubation, ABGA shows pH was 7.27, PO2 was 124, PCO2 was 76, base excess was minus 5.9, and BICAP was 33.9. Post intubation, chest X-ray shows diffuse haziness or lung fields. Uh, this is ultrasonography of lungs. We showed this turbulent white line. we baby was kept on ventilator for 7 days. Ventilator setting was weaned day by day. Maximum mean airway pressure was 15 and then tapered to 8. Syrup azithromycin given for 5 days. And that protocol was started after the consent of parents, after discussing the outcome. Tablet sildenafil, tablet
So why was
spironolactone.
this syrup azithromycin was given for 5 days? Whether we use azithromycin or an erythromycin in such premature babies?
Sir, yeah, azithromycin for in view of in view of BPD, because azithromycin against urea plasma, urea luticum. So
Okay.
The initial
Can
study
you
was
label
done
it as-
actually, I think, on erythromycin. Because of the
Yeah.
erythromycin, there's a high incidence of pyrolytic stenosis and everything. So that's why they did the trial on azithromycin. I think there's a current trial is going on in the UK, like SDEC trial. So they tried the azithromycin 20 milligram per kg for initial 10 days, and we are just waiting for the period. But ultimately, we need to rule out the ureaplasma. And the studies suggest that the baby who has a BPD, they have a ureaplasma is very common in that kind of preterm baby. So that's why it's just a 5 days trial we gave, and because we could not found any sepsis or baby stuck on the ventilator.
Okay.
that protocol was started after the consent of parents. Tablet sildenafil, spironolactone, and thiazide was started and continued.
Okay, so can you label it as BPD at this point of time?
Yes, sir.
Okay, what is the definition? I mean, on what this thing ground can you call it as BPD?
Sir, according to NIH, BPD is defined as oxygen requirement for 28 days in less than 32 weeks of gestation. Label is 36 week of post-menstrual age, and for more than 32 weeks of uh, uh, gestational age for that babies. We can label as BPD after 28 days of photo and 56 days.
Okay, so this is what you told now is actually the older definition of BPD. This was given by the NICHD in 2001. Now in 2018, they have come up with a modification, and what the current definition says is the only diagnostic point is that the child should be dependent on oxygen at 36 weeks of corrected age. Okay, so if the baby is dependent on oxygen, there is no 28-day criteria at this point of time. Okay, the recent definition, what it tells is that there should be O2 requirement at 36 weeks of postmenstrual age. So if the baby is dependent on oxygen on say 36 weeks, you definitely label it as BPD. Okay. Even I mean, like what grade of BPD would this fit in? I mean, because at 36 weeks we don't know what support he was on, but subsequently I think he needed ventilation also. So if the child requires invasive ventilation, it actually becomes grade 1. Yeah, and so okay, for this thing BPD, what are the trials? Or sorry, what are the medicines you can give? What is the management you can do?
Sir, from pharmacological management, we can give dexamethasone, steroid.
Okay, so what is this DART protocol?
So that protocol is the dexamethasone randomized control trial therapy.
Yeah, so it is actually that is what I wanted to point out. It is DART, not DAART, right? So it is DART.
Yes,
That is
yes.
dexamethasone, a randomized trial. Okay. More than that, I mean, what I mean, apart from this case, okay, you leave this case aside. Like, what are the management strategies for BPD? Something. I mean, it starts or for the prevention of BPD rather.
Yes.
How do you prevent a BPD? Yeah, antenatally, what we can do?
Antenatally, we can prevent BPD by by giving steroids to mother. Then
Okay. Antenatal steroids is
postnatally we
associated.
can, sorry.
Yeah, antenatal steroids is not associated with a decreased incidence of BPD. That is what the Cochrane analysis says, right?
Yes, yes.
So your steroid, antenatal steroid gives protection against all the other conditions. It protects the baby against NEC, ROP, everything else. But unfortunately, what they have found is BPD, it is not protective. Okay. Maybe the reason is because of the increased use of antenatal steroids, the preterm survival has increased. So overall, it
Increase.
is not getting reflected. Uh,
So
yeah. What else? Antenatally, what else you can do?
uh, uh, antenatally good nutrition to the mother, and
If at all there is any chorioamnionitis, that has to be treated. Okay. So,
yes.
and yeah. So then
Then
delivery room
postnatally,
management,
sorry.
immediate postnatal period. What all you can do to prevent PPD?
Postnatal management we can do by gentle if ventilation required, then give a gentle ventilation, like to prevent volume trauma and barotrauma, to give volume targeted ventilation.
Okay.
So
So
we
that
can
is all when the baby comes in the NICU. Sorry. Yeah. So that is all when the baby comes in the NICU. Delivery room care. I mean, inside the delivery room, there are certain interventions we can do to prevent BPD. What we can do?
minimal oxygen.
Yeah. So one thing
And
is targeted oxygen. We should target the oxygen saturation between 90 to 95, or
90.
based on the age specific oxygen cutoffs. And second is what is the first thing we can do to prevent BPD? What is DCC?
sorry.
What is delayed cord clamping?
Yes, delayed cord clamping is now advisable to do in all terms and preterm babies who has not require any resuscitation, means all stable baby after
Okay.
so
So I mean, would it be justified if you do DCC in your baby? I mean, if this baby was delivered and if you were called there for attending the delivery, was it justified if you waited for a delayed cord clamp in this baby?
yeah.
I think we had the delayed cord clamping because baby was stable actually. So
So
Okay. So what the study says that if there is presence of Doppler abnormalities, anyway the blood flow to the fetus is compromised. So there is, I mean, you can skip the delayed cord clamping because already in the antenatal period also the Doppler was abnormal. There is, compromised blood flow to the fetus. So for that reason only, actually the pregnancy was terminated. So we could have skipped if there was, if there are Doppler abnormalities, we can skip the delayed cord clamping.
I
Yeah,
think
and
now
what else?
latest I think NRP and everything is suggests that we can do the delay count, but not a milking in the extreme preterm. But I will check the guideline. But I think nowadays in latest guideline, irrespective of the flow or anything, basically to stabilize the blood pressure and the fluctuation of blood pressure in the brain, I think we should give the delay count. But still, I will check from myself. But nowadays people are doing all over delay control even in the extreme preterm, irrespective of the blood flow.
Okay, proceed.
baby from 86 to 100 days of admission, baby was maintaining saturation above 92%, and vitals were within normal limit on minimum setting of SIMV mode. Uh, so baby was extubated after 7 days of ventilation and kept on nasal CPAP. CPAP was gradually weaned, and baby was started on HFNC. Thereafter, it was gradually tapered and shifted to nasal prongs. Nutritional workup was done on regular interval, which suggestive of a persistent consistently raised ALP level. Phosphorus level was lower side. Calcium level was within normal limit. Vitamin D3 level was normal. So calcium and phosphorus supplements given for the same. Repeat blood investigation showed improvement in ALP and phosphorus level. Uh, on 100 to
Okay,
110.
what was the calcium and phosphorus value? I mean, calcium, phosphorus, and ALP value. Beyond what cutoffs we usually take it as?
ALP level, if more than 800.
Okay.
ALP.
ALP level, yes. ALP
Yeah.
levels, if more than 800,
Right.
we can label as a metabolic bone disease.
And what else? I mean, just a ALP of more than 800?
ALP and phosphorus level is less than 4 milligram per deciliter.
4.5, yeah? Less than 4.5 phosphorus, and in ALP, which is sometimes even if it is more than 500, and if it is an extreme preterm, we can take it as early metabolic bone disease.
Yes.
So, calcium and phosphorus in what dose do we supplement if we are treating such baby?
Calcium give 120 to 150 milligram per kg per day, and phosphorus 60 to 75 milligram per kg per day.
Okay.
Of O2 trial was not tolerated. Baby was.
I just want to add it regarding the calcium phosphorus. I think apart from the dose, I think the ratio would be the important thing. Calcium and phosphorus, which would be the 2:1, and in same time, I think vitamin D3 level we have to do in this kind of baby. So, and the calcium is not a good indicator for the osteopenia prematurity. So generally, the treatment is based on the calcium, not calcium, but phosphate, vitamin D3, and ALP. And generally we used to do, if we treat the phosphate deficiency, we generally increase the calcium dose, because if you give the phosphate supplement alone, it will create the secondary hyperparathyroidism, and that's why we have to give the calcium and phosphorus in the particular ratio as per new aspirin guideline. Komal, go ahead. Yeah.
Baby was kept on minimal oxygen support with O2 by nasal prongs. ROP was done. We show immature retinal vasculature. Repeat USG cranium was done, which was also normal. This is imaging. Yes. Anthropometry on admission. Observed weight was 600 gram, length was 34 centimeter, and height circumference was 24 centimeter. All these values is less than third centile according to growth chart. So which suggests baby's symmetrical IGI.
Is it the same as phantom chart or something different?
This growth chart suggests
which chart is this one?
Is it a phantom chart or something?
This is a phantom chart, but I think they put by mistake this one. We have this new IAP growth chart we have, and I think
right.
by mistake she put the phantom chart instead of that one.
On 112 days of admission, baby discharged on 28th May. 112 days of life with oxygen support. by nasal prongs, 0.5 liter. After explaining all the dangers to parents, bag and mask ventilation and oxygen monitoring were taught to parents. He was assessed by physiotherapists for early stimulation and movement. It was found to be normal. Repeat ROP, BERA, and developmental follow-up was organized. OE was normal. On discharge, weight was 2.5 kg, head circumference was 33, and length was 46 centimeter. Uh, Summary: 100 days old male born to primary mother, abnormal Doppler flow, 30 gestational age was 30 weeks and 4 days, deliver in good condition by lower section cesarean section. Birth weight was 600 gram. A small for gestational age, had severe BPD, which required that sildenafil diuretic, rising ALP with low phosphorus level suggestive of osteopenia of prematurity. With normal cranial ultrasound, initially feeding intolerance, no NEC, no PDA, discharge on minimal oxygen with nasal pump.
So was an echo done after diagnosing BPD? When you labeled the child as BPD, was an echo done at that point of time?
I'm not able to. Sorry.
Uh, did you get an echo done after diagnosing BPD? I mean, the initial echo
Yes.
was normal. Yeah.
Yes.
So what were the findings in that echo?
Uh, After diagnosing a BPD, that echo suggestive of mild pH. Otherwise, it was normal. No any
Okay.
structural or any functional abnormalities.
Okay.
There was also the flattening of interventricular septum, basically, and there is no PD actually. So, but there is interventricular septum flattening is one of the sign for the PAH. So that's why we treat it as a sildenafil. As such, if we see the history, the sildenafil we can give as an adjuvant therapy in the BPD. There is no any specific role, but if we give with the severe BPD, sometimes it improve the pulmonary compliance and decrease the pulmonary pressure, and we will get some time to deal with the high ventilation setting.
Right.
So my diagnosis is a single preterm 30 weeks and 4 days. SFD, intrauterine growth retarded, severe bronchopulmonary dysplasia with osteopenia of prematurity, and grade 1 NEC, feeding intolerance with anemia of prematurity and apnea of prematurity.
Okay. So what counseling would you do? Grade 1 initial. Just now we discussed there was no initial.
Yeah.
And what counseling would you do to the parents? I mean, at discharge, the parents would want to know that what would be the long term outcome. So how do you counsel them?
First of all, we explain the parents regarding the long-term outcome, like baby baby's IUGR. So weight gain uh, issue will be around, like weight gain would be less compared to normal babies, and in view of a BPD, baby can develop severe respiratory infection in after 2 years, within 2 years or 2 to 5 years of age. And because we started that, so neurodevelopmental outcome, because uh, neurodevelopmental outcome of this baby also explained.
Okay. So even if you don't start that, BPD as such by itself is a indicator of poor long-term neurological outcome, right? So even if you don't give a DAT, if the child is having BPD, definitely the neurological outcome may be compromised later on. DAT is something which was essential in this case. Even if you don't give that, BPD as such by itself is an marker of poor neurological outcome in the long term. And also these babies are more at risk of restrictive lung disease. Okay, they may have some asthma or restrictive lung disease at a later stage of life.
There is some voice coming.
I think Sandeep sir's OPD. You can mute.
Yeah, it's done. You can just stop screen sharing if there are no questions.
Is there any further question? Dr. Sandeep?
No. Yeah.
So please stop screen, Komal. Yeah. So can I request Shreyashi to present a certificate of appreciation? Though there were some technical glitches, but we were able to witness a nice case with two experts.
Yes, sir. I'm just sharing.
An excellent case, excellent questions, and a good guidance given by both the experts. So Shreyashi, on behalf of NNF Gujarat,
Yes, sir.
we like to present a certificate of appreciation.
Yes, sir. I'm sharing.
We are thankful to Dr. Vishal Goel, who motivated Komal for presenting a case in front of all. And throughout the case, there were more than 50 participants on Zoom, and few were there on the YouTube also. So thank you, Dr. Vishal Goel.
Thank you so much.
We also thank, next slide please, Komal Mendapra for presenting a case, though there were some technical issues, but she has presented a case well, as well as managed the child well. So thank you, Komal.
Thank you so much.
We are also thankful to Professor Dr. Vijay Sir. He was the one with whom we have started a neonatal Pathshala, and today, after 1.5 years, we are doing it regularly every Wednesday. So thank you so much, Dr. Vijay.
Thank you, Prashant. Thank you.
Hello.
Yes.
Sir, Dr. Manoj Agarwal this side. I want to ask, can we give and repeat dart therapy? I mean double or third times, if there is any role for repeating the dart therapy?
Yeah, Sandeep, can you just, Dr. Sandeep?
Yes, sir. Yes, sir. No, at this point of time, definitely no role of repeating a dart. As such, I mean, steroids is something which, you know, we are skeptical in giving because of the, you know, it worsens the long-term neurological outcome. And the repeat course of dart, it is, I mean, nowhere, at least I haven't come across the literature at any point of time that, you know, somebody has repeated a course of dart. I think 10 days of steroids is quite a good amount. If the baby has to respond, it should respond usually in that period of time. Repeat course of dart is something not recommended at this point of time.
Okay, because in my two patients, I had trial the second time the DED therapy. In the both conditions, there were the good result. First time oxygen was needed minimal, but after giving the second dose of the DART therapy, after 5 to 7 days, totally we can do the wean of the oxygen. In my two babies, one was the 750 gram and other one the 780 gram.
Okay.
I think the another thing is that like when you think about a dark protocol, I think they update the result in 2014 and they show that if you give the dart at between 2 weeks or between 2 to 7 weeks of the age, then you will get a great response. And if you give more than 8 weeks, then I think there would be there's not that much improvement in the BPD. The second thing, there's a few trial they gave the prolonged dart like initially first 5 days, 3 days, but there is no any advantage on the BPD. So I think they stopped the trial for that one. The important thing would be that if you treat any baby with the DART more than 8 days, and if baby has a severe BPD, then there would be more advantage of the more advantage in point of the BPD, and there is a less likely to that the CP rate would be less if you give in the severe case. But if you give in the mild to moderate case of the BPD, then there it has a very bad neurological outcome. So when you start the DART, I think better see that criteria, and the counseling should be done, must be done with the video recording, or either we have to take a formal consent in nowadays, and that's we need to inform day by day what's the progress for that one, what would be the short term and complication and long term outcome.
Okay. So one more question. Can we repeat the spironolactone or diuretics, I mean furosemide simultaneously if we are suspecting the BPD?
So furosemide, I think they start because I think on initially like for example why the furosemide is come in the picture basically. The initially for the people are used to give a furosemide with the RDS, and when they give the single shot, they will say that there is an improvement on the oxygenation and there is a decrease in ventilation day. So that's why they think should we try in the BPD. But if we see the trials like furosemide with the placebo, there is no any additional advantage, and baby has a same ventilation day, no any advantage on the long term outcome. Even there is a lots of trial is going on with the hydrochlorothiazide and the spironolactone, even though there is no any advantage in the BPD, and there is no any even there is the same electrode imbalances happen if you use either furosemide or spironolactone or hydrochlorothiazide. The only advantage would be it will give the time to the baby to improve their compliance if baby stop on the ventilator. So short course you can give like for 1 week, and you can see on your ventilator setting that a baby has a now decreasing FiO2, decrease the MAP. Other than this, there is no any role in the BPD.
Okay. And there was particular any role of the SMV volume control mode? Just in this case, we had used the SMV volume control mode instead of the pressure control mode. There is any benefit?
Yeah, so volume guarantee is always we have advantage because if you give a more pressure, then definitely it will damage more to the lung. And there's a lots of study like volume guarantee versus pressure control, and they show there is less ventilatory days on that baby, less chances of BPD. And we can also see that that if you set the volume guarantee, like for example 5 ml per kg, and you can see the day by day the pressure will be decreased from 20 to the 18. And also if you start with the first day, there is a less fluctuation of the blood pressure, less hypocardia, less hypercardia, which prevent the PVL, which prevent the IVH. So there's a more advantage to start with the volume guarantee.
Okay, thank you. Okay.
So thank you so much. And we are also thankful to Dr. Sandeep for asking wonderful questions and being an expert in this session. We request everyone to join next Wednesday at 3:30 p.m. by joining the same ClearNet and YouTube link with neonatal Pathshala with different topics. Thank you so much.
Okay, sir. Thank you.
End the meet. Thank you.
Thank you, Prashant.
Thank you so much, everyone. Thank you so
Thank
much.
you. Thank you, Dr. Sandeep, Dr. Vijay, sir. Thank you so much.
Thank you.
Thank you.